Welcome everyone to Fridays afternoons intensive care teaching. We are very lucky today to have Amy Webster, who's one of the consultant haematologists at Leicester Royal Infirmary, talking to us about TTP and thrombocytopenia. Amy, all over to you, really.
Thank you. So thanks for asking us to talk. And I guess the motivation behind this is partly just a sort of mutual learning, but also recognising that there are going to be some changes to the service and sort of just trying to make sure that we're all aware of how that's going to change. But I thought I'd start by just thinking about thrombocytopenia in general, which clearly is something that you come across very commonly in intensive care, and the idea behind this is when a platelet transfusion might not be the answer, because I think as a haematologist, quite often we just end up authorising platelet transfusions, but actually it's important to think that sometimes that might not be the response we give, and actually why might we be in that situation. So what I just wanted to do first of all is just for us to consider some common causes for thrombocytopenia, particularly in ITU. Think about what are the indications and contraindications to a platelet transfusion, and then using a case study for further discussion. So, as I said, we are using Slido, and this is the Slido number. So I hope you've all used Slido before. If you just go on to Slido in Google, then you can usually just find the link to be able to join with the hashtag number. There are only 3 questions, so don't worry, it's not going to be too onerous, but it's just to kind of try and get some interaction in the best way possible, which I know is difficult using these sorts of forums. But what I want us to think about first, and this is just in the context of what we define as the definition of thrombocytopenia. From a haematology perspective, a platelet count of more than 100 to us is generally not something that we particularly worry about, so it would kind of fall under the category of mild thrombocytopenia. If you're getting to moderate thrombocytopenia, sort of between 50 and 100, then clearly you're thinking about what's the impact of that in terms of if someone needs intervention such as surgery or kind of procedures, but also if a patient's on from anticoagulation, what's the bleeding risk associated with that. So those are the kind of levels that we start to become a little bit more interested. And then particularly when we're thinking about severe thrombocytopenia, when the platelet count is less than 50, we're talking more now about those instances where either bleeding or hemostasis is not going to be achieved normally, and so therefore you're thinking about what are the indications or what are the conditions that might lead to that degree of thrombocytopenia and how are you going to manage it. So if you just think about the first Slido question, so what are the common causes of thrombocytopenia that you will generally see on ITU? And I'm just going to share my other computer to try and show the slide. Okay, so the comments that we've got so far that I can see, apologies, I can't share it, but we've got things like medications, DIC, sepsis, bleeding, HIT, very common causes of thrombocytopenia. Any particular medications that, other than heparin, which people have already kind of alluded to, that people think are common causes that we see? People want to put those on. Yeah, Netherlands a good one. So I guess antimicrobials as a general rule. Yeah, so I think, but just thinking about drugs and the kind of the underlying reasons why the patients are on ITU in the first place. But just, and it'll be interesting just to kind of get in the chat how common people think, how common people feel that thrombocytopenia is on ITU, because I guess to a haematologist it feels like everybody has it, but in that context I don't know if you depends on what kind of ITU you're working in the context of the patients with which you're looking after. I think VITS is an interesting one. We will come back to VITS later on because I'm not sure how many of us that have been involved with managing these patients, but I hope it's not something that we're going to be managing again too much in the future. Yeah, and then help. So thinking about obstetric reasons in the context of the patients that we're caring for. So that's just to sort of get people thinking about common reasons why thrombocytopenia might be present on ITU. So when we're thinking about treatment for thrombocytopenia, clearly the underlying cause has to be taken into consideration. So for a lot of those causes that people have just highlighted, it's whether or not you can replace that medication with something else, or just treating the underlying cause, such as treating the sepsis. But what we think about in terms of when treatment is required is the patient bleeding? So therefore, are you worried about the need to prevent bleeding? Is bleeding already happening, and therefore a platelet transfusion is indicated to try and help hemostasis occur? But also, are procedures likely to be required? And clearly that is something that is a common occurrence for your patients in ITU. So I just want to kind of let us think about this patient who some of you may recall from his stay on ITU last summer. He's a 51-year-old male. He presented to his local hospital with fatigue, some chest discomfort, bleeding and extensive bruising. He'd recently returned from a holiday in Pakistan, but he'd been well whilst he was there, and his only past medical history was psoriasis, for which he'd not had any kind of systemic treatment. So clearly there are things in his history that just sort of make you think that there is a hemostatic problem, but we probably don't know enough in order to recognise or get an idea of what else is going on. So from a haematology perspective, what normally happens is that you'll get the full blood count, and this was his full blood count, and you can see that clearly most things are red, so it's highly abnormal. So as I said, most things are red and abnormal, but in this case, as I said, we're highlighting the platelets in particular. So he has a platelet count of 14. And for those of you who have never kind of worked or had much experience in the laboratory, this is the kind of full blood count that the laboratory would actually automatically get flagged to the biomedical scientist, whose then responsibility is to sort of look to see, is there any clear reason why the sample results are abnormal? Is it a sampling error? Or is this a true reflection of what's happening in the patient? And if it looks like it's a correct sample, then the laboratory will automatically make a blood film, because the morphology can give you a lot of information to sort of know what's going on. So in terms of what can morphology tell us, so one of the commonest things we'll see is something like this. So for those of you who aren't morphologists, these are white cells, these are red cells, and these are platelets. And this is just a clump of platelets. So very commonly you will find that you will see a provisional platelet result, but then soon after the result will have been taken away, and that's usually because the BMS has seen clumping under the microscope, and therefore they don't feel that that platelet count is a true reflection of the patient's true platelet count, and we need to think about what else is going on. More worryingly, we might be looking for this down the microscope. So these are leukemia cells. And in particular, this little line here tells me that this is most likely to be acute myeloid leukemia. So the history in this context, with someone being quite acutely unwell, you would want to know that that's not what's going on. Or in this case, what you can sometimes see is not very many platelets at all. So I can tell you that this is a very low platelet count. And in this is sort of what we sometimes see if people have severe immune thrombocytopenia. You don't generally see anything other than the fact that there aren't many platelets there. But common things are common. So this would be something that we would see with something like a viral infection. And then this is something we're seeing increasingly. So these are your red cells with malaria in them. So this could easily be how malaria would present in the context of the history, although a platelet count of 14 in the context of malaria would signify quite significant malaria infection. So I will tell you that's not what was going on, but it just tells you that how much information you can get by looking down the microscope. But in this particular case, what we're worried about seeing is something like this. So this is what we would describe as something called microangiopathic hemolytic anemia, which is a very fancy term. But basically what we're looking at are these abnormal red cells. and this is what we call fragments. And when we're thinking about fragments in the context of thrombocytopenia, thinking about the condition MAHA that I've mentioned. And what this basically is a non-immune hemolysis. So it's not being directly related to the immune system, but there's red cell breakdown due to intravascular fragmentation, and that's what you're seeing. And this is quite common in lots of different conditions. Because there is hemolysis, you will see things like a reticulocyte response because the bone marrow is responding to it. You'll see your bilirubin go up. You'll see a raised LDH consistent with red cell turnover, but your direct antiglobulin test will be negative. So if you had a positive DAT, then that would fit more with an immune hemolytic process, but that's not what's happening here. So what we can sometimes do when we see MAHA is think about what's actually happening in the context of the patient. So for those of you who work in obstetrics, this is a very common finding, particularly associated with things like severe preeclampsia or other sort of severe complications such as amniotic fluid embolism. Severe B12 or folate deficiency can give you this picture. Pregnancy can, post-transplant, so particularly bone marrow transplant, you can see MAHA. Hypertension, so malignant hypertension can cause this feature. Also common things, so infections, connective. So clearly, MAHA in itself is a pathological term. It's not telling you what's going on, but it means that you have to start thinking about these underlying conditions. And when you have a condition called MAHA, when you also have thrombosis in the vessels, that's when you're more worried about a thrombotic microangiopathy. And what this is basically telling you is that the platelet count is low, but actually the patient is forming clot in their small vessels. And that's actually quite a pathological feature of several conditions. And this is just purely taken from Up to Date, and you can see that there are lots of different reasons why you can get this this finding, some of which are more related in children or more common in children, some of which are related with kidney injury. So clearly it's knowing what the underlying features are and the underlying clinical context. So if we come back to our patient, he had MAHA. He actually had a normal renal function and he didn't have any history of diarrhea. And as I mentioned earlier, the history was very acute, so fitted with something acute. And if you follow this pro forma in terms of thinking about what the diagnosis might be, we are brought to think about something called TTP, which Ricky mentioned earlier. And TTP is a very rare condition, but it also has a very, very high mortality rate. So it is something that we need to be able to diagnose and need to be able to recognise and treat quickly. So in this case, we think the patient's got TTP. And in that case, from a haematology perspective, TTP rings massive alarm bells. If it's 2 o'clock in the morning, I am getting up and getting out in my car and driving to the hospital. It's that level of fear in the context of a haematologist. So TTP, for those of you who aren't aware. So TTP is due to a problem with what's happening in the blood vessels. And basically at a very, very kind of basic level, you're getting these big lumps of von Willebrand factor that aren't being broken down, and that's consuming your platelets. So there is a deficiency of something which usually breaks down your von Willebrand factor, and that something is called ADAMTS13. I don't think you need to necessarily know that, but I guess what you need to recognise is that there is something missing, and the resulting problem is that there is low platelets, but also microvascular thrombosis, which can then cause to thrombotic complications. What that then occurs is that you then get widespread organ damage. So I've already said that this condition has high levels of morbidity and mortality, and the literature still quotes that if it's untreated, the mortality is more than 90%, but the survival is more than 80% if patients are treated in specialist centres. And time is critical, because the quicker you can instigate the treatment, the quicker you can try and get on top of this process, which is occurring in the small vessels. So I mentioned earlier that things may change, and the NHS has kind of looked at TTP and thought this is something that we need to be doing properly. And actually they've recently commissioned specialist centres. So there are 8 specialist centres across the country, of which Leicester is one, in partnership with Nottingham. So we are going to be a specialist centre for TTP, and we are going to be taking patients in from referral centres in order to manage and treat them. But nobody is saying that this is an easy thing, because clearly there are very strict needs from the point of view of getting these patients to the right place and getting these patients to the treatment that they need. If we just look at what this actually is telling us we're going to need to do, we're going to need to arrange transfer for the patients to wherever they need to be, to arrange urgent central venous access. We need to do bloods for diagnosis, but also for prognosis. We need to commence PEX, which is plasma exchange. And you can see here that what we're actually being told to do is from referral to onset of treatment needs to be less than 8 hours. So there are kind of time critical needs in the context of. And then recognising that some patients will be more sick than others. So I mentioned troponin as a prognostic marker. So for patients that have cardiac involvement or neurological involvement, those are both seen as very high risk features. And in those cases, we also need to suppress the immune system, because ultimately it's the immune system which is causing this problem due to antibodies directed at the protein that I mentioned earlier. So lots of things that we need to sort of try and do in a very short space of time, some of which we will come back to later in terms of how we're going to be able to. But I think one of the issues that quite often comes up with TTP is these patients are presenting with a platelet count of 14 in this case, and we want to put in a line in order to be able to give them treatment, which more than often needs to be a VASCAF. Is actually, are you going to have problems with bleeding in that situation? And the evidence tells us that clinically relevant bleeding is actually very rare. So even in the presence of very severely low platelets, because the patients are actually prothrombotic, concern with bleeding is actually not significant. And actually there is some observational data that suggests that patients were more likely to have thrombotic, as in significant thrombotic events, if they had a platelet transfusion. So it's one of those situations where we're going to say, no, just do the line, it's absolutely fine, they won't bleed. But I would be interested in the next question, because clearly a lot of you are people who are putting in these lines, and it's all well and good me as a haematologist saying, yep, that's absolutely fine, please go ahead and do it. But actually, at what level of platelets? In the context of any patient, not necessarily a TTP patient, but at what level of platelets would you feel comfortable to insert a VASCAF? Let's see if people can give us their responses. So I'm just seeing some responses come in, which I think it would be interesting to try and share, but I can't quite work out how to do it on both computers. But so far we've only got 5 responses though. So, but what I will tell you is that it is quite mixed in the context of what people are comfortable to do. So what I will tell you so far is that we have the majority of people feeling that they are able to give it at any platelet count because they feel able to manage the risk. So that's 38%. For the other results, the second most common is more than 20, then more than 50, and then supported with a platelet count less than 30. So what that kind of tells us is that there isn't a consistent approach in this situation, and clearly it is an individual decision. But what I'm trying to sort of make people feel confident and comfortable about is that in the context of this particular situation, a platelet transfusion may actually be harmful. And I think that's just sort of something I'd be quite interested for us to discuss once I've finished my slides. I'll leave that open so that if anyone wants to keep adding to it, I can reshare it again at the end. So as I've said earlier, in terms of platelet transfusion in TTP, the national guidance is to avoid supportive platelet transfusion unless there are significant additional bleeding concerns. So in that context, what I would say is additional bleeding concerns is maybe someone was on anticoagulation or they have another bleeding diathesis, such as coagulopathy due to something else. So those are the kind of things that would make me a bit more wary. And interestingly, the National Blood Transfusion Code suggests that a platelet count of more than 20 is adequate for a central line insertion. But again, I'd be interested to know whether or not you as experts in that field would see a standard central line against a VASCAF being different. So I mentioned plasma exchange. So for those of you who have not seen our machine, so this is what our machine looks like. Interestingly, we are just about to get a new machine, so I don't know if it's going to look exactly the same. But basically what plasma exchange is doing is it's spinning down the blood, taking out the bit that you want to remove, which in this case is is the patient's plasma, and then you need to replace it with a replacement fluid. So we can do exchange for different reasons. So we do red cell exchange in the sickle cell patients where we're taking away their red cells and giving them back transfused red cells. But in this particular context, we want to remove the plasma because that is where the antibody that's causing the problem with the ADAMTS13 deficiency is present. So plasma exchange in TTP, we routinely do 1.5 plasma volumes, and we use a special FFP or fresh frozen plasma called Octaplas. The reason we do that is that it's often large volume that's required, and therefore using something which is treated is felt to be safer from a viral risk. But actually there's also evidence that that protein that I said is deficient is actually found more plentiful in Octaplas. So as well as taking away the antibody that's causing the problem, you may also be replacing some of the deficient protein. And in terms of what we need for plasma exchange, we need vascular access, and you do need to have good flow rates. And actually in a patient with TTP, you are likely to need to have repeated procedures. So we have to think about vascular access in that context. So quite often, as I said, a VASCAF would be what would be required in this situation. So there are other indications for plasma exchange. So these are what is classed as category 1 indications. So TTP is probably the most important from a haematology perspective. Renal do their own plasma exchange, so that's not something that we would necessarily offer from a haematology perspective, but you may well have encountered situations where patients with significant neurological conditions have been treated with exchange on ITU. The risks associated with plasma exchange, so most commonly it's related to the line, which I'm sure you're all aware of. We do have to anticoagulate the system, and we use citrate, which means that calcium depletion is fairly common. And although in this case we use Octaplas as our replacement fluid, if you're using anything else, then you do sometimes find that you can get quite significant depletion of the clotting factors, and in particular if fibrinogen needs to be monitored and replaced. So I think that's something that we've certainly seen when we've done plasma exchange for neurology patients previously, that we are having to give them additional supplementation with cryofibrinogen in order to kind of keep on top of that. So if I come back to this patient, you may recall that he was in another hospital. Unfortunately, that hospital could not deliver plasma exchange due to some staffing issues and some local issues with operational issues. So basically they were 2Bs and they didn't have someone that could do it. Unfortunately, we're already 24 hours on from when he presented to his hospital. So we're already thinking in the context of TTP, there have been significant delays. And sadly, he was put in the ambulance and had a seizure and a cardiac arrest on his transfer, and arrived post-ictal to the Royal and needed to be intubated in ED. And in this context, seizure activity reflecting significant neurological involvement with TTP is a high-risk feature, as I kind of alluded to earlier. So he did have a scan, he didn't have any hemorrhage, was admitted to ITU, had all of his lines inserted, and then his plasma exchange started a couple of hours later. Unfortunately, as I said, there were some delays to his suspected diagnosis, and that was partly due to an initial suspected diagnosis of ITP because some of the hemorrhagic features. But I think clearly the biggest factor here was the delay to plasma exchange provision at the local centre. And I think we did quite well in the context of the situation in which the patient was in, clearly having to manage his seizures, having to stabilise him before we could proceed to his plasma exchange was the right thing to do. So in that context, we would have been within the guidance in terms of initiating the treatment at the Royal, which is a testament to all of those involved at the time. But sadly, there were ongoing issues with his ongoing care. The plan had been for him to go back to the treating hospital, but that didn't happen. So we ended up giving him further plasma exchange here. Caplacizumab is a monoclonal antibody that is specific treatment for TTP. But again, I wouldn't necessarily expect that to be something that you need to know about. But clearly he had high risk features in the context of his neurological involvement. So we gave him rituximab, and sadly his renal function started to deteriorate. Again, all of which is suggesting that he's not going to do well from the point of view of his TTP. And unfortunately, he did then on the following day become suddenly unwell. He had bedside echo, which showed significant impairment of the right ventricle, and he arrested, and the decision was not to offer him CPR, which I think in the context of his clinical picture was the right thing. So that's just what I wanted to highlight from this case actually is how TTP goes wrong when we don't get it right. So those issues I mentioned earlier about the delays to his diagnosis and the delays to his treatment, wherever they occurred, whatever the situation was. And I think it's important just to recognise that TTP is not the only prothrombotic condition where there is low platelets. So one of you mentioned earlier heparin-induced thrombocytopenia, and this is certainly one of those instances where we need to be very aggressive about anticoagulation despite the thrombocytopenia, thinking about how we manage that. I think Ricky might be able to tell us more about complement-mediated TMA, because this is usually significantly associated with renal impairment and therefore managed by the renal team. But also you mentioned, or one of the team mentioned earlier, VITS. And VITS was a very significant complication of the AstraZeneca vaccine, which did cause a very TTP-like presentation. And a few of you may have been involved in patients who were treated with plasma exchange for VIT previously. So I think they are the conditions that, although they don't have the same underlying pathology, they do tend to cause a very similar clinical phenotype. So I've kind of whizzed through that, partly just to sort of make sure that we covered everything and had time for conversation. But what I'd like is just to sort of people to think about what are their takeaway learning points from a case like this. It might be related to something I've already mentioned, or something that I might not have picked up on, particularly from an ITU perspective. So I'd be interested if people could just maybe give us a couple of words in terms of takeaway learning points. I'll open the poll now.
Amy, do you mind if I ask a question just whilst waiting for?
Yeah, fine, of course.
Out of interest, how do you do it in terms of how did you deliver the plasma exchange on the ITU? Do you take that machine that you showed a picture of, and does that go down for the ITU?
Yeah, so we have two machines. They're both portable, and we have an apheresis rotor within haematology. And when there is a suspected TTP, the haematologist will call the apheresis nurse. They will go to day ward where the machines usually live, and they'll take them to ITU. Which in this case is usually fine, but we did find with some of the VITS cases who we had to treat, because of COVID at the same time, it was really challenging because you didn't necessarily have somewhere to be able to take the machine to. Yeah. And that did cause quite a lot of challenge. But yeah, no, the machines are portable. It's the practitioners that are because it is a very unique skill.
Yeah, I mean, certainly in renal, that's the same challenge. It's the getting the right staff, and inevitably it sort of stretches everything to breaking point, really.
Yeah, and I think you're right. I think it's not necessarily the first treatment that's the problem, because people see the significant difference that plasma exchange has in TTP. So if they know there is a TTP patient that needs urgent treatment, they're there, they come and do it, and they're really motivated to do it. The challenge comes that it's the knock-on effect of the following days. So for a plasma exchange, for TTP, you're likely to need to exchange someone for 5 or 6 days, usually. And if there is pre-existing activity on the apheresis machine, so our apheresis machines are used for stem cell collection, they're used for the planned red cell exchange. So if there's already somebody booked on the machine, then it's how do you then juggle that workload the following day in order to try and make sure that there is someone that can take it over to ITU. And one of the things that we have done is we've got a third machine. So one of the local cancer charities helped us to raise some money. So we've just bought a third machine in order to help support the wider apheresis for haematology. And that just gives us a bit more flexibility in the context of having that extra machine to be able to be more portable.
Amy, can I just come in there?
Of course you can.
It's Alex, yeah. As we're all one trust, and you've got two sites that are doing apheresis, is it worth combining forces and making a more, I don't know, responsive service?
So we're looking into it. So with the IVIG shortage last year, there was an issue accessing IVIG for the neurology patients, and this caused some problems with them asking for plasma exchange, and that highlighted, I think, the apheresis capacity across the organisation as a whole. So Colette Marshall set up a group towards the end of last year, and I am working through getting all of the information from all of those sites that currently do apheresis, and sort of trying to get a more coordinated approach. The challenge is, and Ricky might want to come in on this, is that we use different machines, and so in that context, we can use our machine for everything that we need to do, but we can't use the renal machine for everything that we need to do. So there are some haematology treatments that need the apheresis machine that we have. Is that a fair comment, Ricky?
Yeah, I think that's pretty fair. I think you're right. It's difficult because I suppose we've got indications in renal that we use it for kind of on a, well, I suppose the things that we're sort of very familiar with, like the vasculitis and the transplant antibody mediated rejection, that it's not quite bread and butter, but we do use it fairly frequently. I think we are trying to change to a slightly different machine, which I'm sure won't be the same as your type of machine, actually, which is a bit ridiculous, but yeah. But again, it's what our nurses are kind of used to, I suppose.
Yeah, so I think that's right. It's the practitioners that are the biggest resource here in the context of in terms of the capacity rather than the machine itself, I think. But it is being looked at, and Andrew Furlong has kind of tasked us with looking at it. So so one of your colleagues has sent me through lots of information, and I'm trying to pull it all together, Ricky. So we are working on it, Alex. So in terms of comments that we've had come through so far, I think a lot of people just recognizing that how adequate treatment or the correct treatment with regards to TTP leads to a better outcome, and the need for early treatment. So those are kind of the kind of key takeaway points from our perspective. But what I also just wanted to highlight, and Alex might want to come in on this, is just, as I said, UHL and Nottingham have kind of jointly been awarded the service for the East Midlands, and we are technically starting on the 1st of April, although we are already offering this service, so it's not anything new that we're doing. It's more just to do with the fact that we're having to fill out a lot more paperwork in order to be able to give feedback on how we're doing, but clearly it is actually quite a prestigious thing to be doing. There are only 8 centres in the country, and therefore we want to be doing it right, and it is going to take close coordination between us as haematologists, you as ITU, but also the apheresis team that I've already mentioned. So we have been working on kind of protocols in terms of admissions, and one of the things that we have recognised, is that these patients generally have the potential to become very unwell, and clearly need to be in the right place in order to be able to get access to the right treatment, but also the vascular access for facilitating that treatment is really important. So we've had several conversations about it, and Alex and Gareth have been very supportive of these patients being admitted to ITU in order to facilitate that initial treatment, with the understanding that those patients then, if they don't have any ongoing need for ITU input, then they will be discharged to haematology with ongoing input. So we do have everything in place in terms of, as I said, apheresis, rotas for the nursing staff, backup between the organisations in terms of capacity, and there are conversations ongoing with EMAS in terms of ambulance transfers, because in terms of our outreach centres, the places that we're going to be offering this service to are Kettering and Northampton. Again, both of whom we already take patients from. So in the last 5 years, we've taken patients from both Kettering and Northampton and treated them successfully. So in that context, we know that it's possible, but the needs in terms of the ambulance transfers and how to get the patient to the right place is something that I think is going to need us to just be more mindful of. So this is still in draft, and I think it has been sent round for comment, and I'll take any. Wanted to ask a bit more about the service, but the takeaway messages that I wanted people to have is that TTP is rare, so we are expecting, I think NHS England is expecting 12 patients across the region in a year, and Nottingham does have a slightly higher footprint, so the likelihood is that they will have slightly more patients than we will. Not all thrombocytopenic patients need a platelet transfusions, and in patients such as this, it may actually potentially cause harm, but we also need to be looking for and treating underlying causes for low platelets. So those are the end of my slides. I'll just come out. I can see. Just see. Yeah, so this comment about ACOTs, I think, is an interesting one, because I think there have been national conversations about this based on apparently what's classified as a category 1 in London is different to what's categorised as a category 1 in the rest of the country. So in London, TTP is classified as category 1, but it isn't. It's a category 2 in the rest of the country, and it's not going to become a category 1 because that's for patients who have already arrested in that context. So there has been some conversation about ACOTs in terms of facilitating this, and I think if clearly there is a need for ITU input at the referring centre, then that's appropriate. The challenge will come is that if it's going to be a kind of award to an ITU transfer, how you facilitate that, and I'd be interested in people's thoughts on that. Okay, so I can see a comment there that might help in terms of being able for us to process to move that forward. I think there was some conversations about commissioning and whether or not that TTP is considered in the commissioning for ACOTS, but I know that it is how some hospitals around the country are planning to transfer their patients. So particularly for Bristol, they cover the whole of Devon and Cornwall, and all of their patients were going to be transferred by ACOTS. Gareth?
Hi, Amy. Sorry, I've missed a lot of this. Unfortunately, I was having to do an emergency appraisal to prevent myself being sacked, which I've just finished. But yeah, I think the ACOTS conversation is a good one, and I think it's worth bringing up. I think Susan Dashy is aware of this commission service, and certainly my view would be, I might be being simplistic here, that if patients are being moved as emergencies from one site to a critical care area, then they might well be happy to take part in that and be available. I think it's capacity at the moment. I think we have 2 ambulances, one at Glenfield and one at Park somewhere near Newark. But I think I'd be happy to take that up with Susan, because I think they are still building the service and looking for, business cases for that investment and build up. So I'll carry that to Susan and get back to you, Amy.
That'd be really helpful. I am also aware that I think there was a national meeting amongst the TTP lead and whoever commissions ACOTS nationally about this. So it might be that we get some steer from them as well.
Absolutely.
I've got another hand.
Me, Amy. All I was going to say is if we had a neurosurgical patient on the ward in another hospital or here that needed to go to QMC, then it's exactly the same case. It's urgent treatment. They either get brought to ITU or tubed on the ward, and then they get moved. So I think if it was put to the referring centre that they come to ITU, but it's an immediate transfer out, then I think that sounds very sensible. ACOTS should have no issues with that at all.
Can I ask a question then? If ACOTS do a transfer one way, do they then repatriate I guess they're bringing their own medics, so they don't have to worry about a medical escort from the referring hospital. Is that fair? So ACOTS takes their own medics with them, don't they? They don't. It's like a retrieval. So yeah.
Yeah, no, they do.
They
have standby.
Yeah.
Transfer specialists. Yeah, so the medics and a transfer nurse and the kit and caboodle and ambulance. It's a complete bundled up service. Yeah.
Okay, thanks. I think, is it Seema? Sorry, I'm looking at 2 screens. Samir, have you put your hand up first? Did you want to ask a question?
Hi, thanks, Amy. No, just to confirm that, because I work on the ACOTS some shifts, and we always have, well, not always, but most of the time we have 2 teams who can manage these quite safely. So it's worth a go, really. And we have done transfers for level 1 and level 2 from other sites, like neuro transfers from A&E as well.
Yeah.
So not necessarily only level 3 transfers to be done.
Okay, that's really helpful. Thank you. So it's kind of more about the acute, what the clinical situation is, rather than the needs of the patient at that time.
Yeah, there is a flexibility in the system, but it's a new service, so we might need to gauge the demand and then upgrade it from there.
Thank you. And then the final hand that's up looks like it's from the LRI room.
Yeah. Can I ask a question? Because this patient doesn't look like he's fulfilling the classic criteria for TTP. Can we establish the diagnosis of TTP without having all the 5 criteria of fever, renal impairment, and neurological impairment, thrombocytopenia, and anemia?
Yeah, you can, and I think there've even been some cases of TTP where you haven't seen fragments initially, so you may not have Bond or Maha, but if there's evidence of thrombocytopenia in the context of hemolytic anemia, then TTP needs to be considered. So, and actually, renal impairment tends to be less of an issue, and so therefore if a patient's got Maha with significant renal impairment, then usually that makes us think it isn't TTP, and so we would usually go down the route of advising renal involvement for kind of the HUS or atypical. That tends to be more of the challenge there, but the thing is that it's just about suspecting TTP, and as you say, if the classic pen tag's not there, you still don't just discount it, you take the patient's clinical features into account, and we are not it's actually quite uncommon that we exchange someone that doesn't end up having TTP, so the clinical acumen of kind of picking it up is actually quite high, but that doesn't mean that we don't want to miss any either, so we will always err on the side of exchanging someone if we think clinically it's TTP, because we don't get the Adams level back generally until the following day, even if you sent it urgently, so you would have to exchange them whilst you're waiting for that result to come back. Anything else that anyone wants to add? Paul, from a haematology registrar perspective, is there anything else you think I needed to highlight?
No, I don't think so. I think it's really from us picking up the original concern about the diagnosis, and then I think once the decision's been made to exchange, then it's trying to get that sorted, and that's always been very easy from our point of view, having the rota, and they've always been very amenable to coming in, the nursing staff. So I guess it's from our point of view, where would a patient go in the initial stages? Sometimes I guess it seems that they're usually sort of within haematology, and then if they have a complication such as a seizure, then they end up moving to ITU. But I guess it'd be where would that continue, or should there be a sort of a place that they go until they've had, for example, had their first exchange and are maybe outside of the risk of having seizures or more complicated complications of their TTP?
So yeah, thanks, Paul. And if I hadn't made it clear, I think the agreement has been that these patients will be provided that they are an ITU candidate. The patients will be admitted to ITU for that initial treatment to facilitate that, provided that everybody. I think Alex and Gareth were happy for us to kind of go down that route in terms of the protocols, but I think it is important from the point of view of the haematology registrars to know that that's what's going to be happening at 3 o'clock in the morning.
Yeah, Amy, Alex here again. I totally agree with that. I mean, I think that, you know, we brought it up at the consultant meeting a few months ago, and I think we're all very supportive of the service. And you know, if the patient would be a candidate for ICU, their mortality for having this disease is high, so therefore they do deserve, you know, the treatment that we can offer them in an emergency scenario. But it does come down to sort of communication, doesn't it? Diagnosis, communication, and everybody singing off the same hymn sheet at 3 o'clock in the morning. So yeah, thanks.
Yeah, and I think one of the benefits of this service specification has been that we're so much better at talking, not just internally, but also with our Nottingham colleagues, just sort of knowing what's going on. So I think I'm sure it's not a problem for me to say this was Nottingham this patient came from, and actually it hadn't been until that point that we'd known that they were having challenges with offering apheresis, and actually now they're telling us those days they know they haven't got the capacity to do it. So at least we have that knowledge in order to be able to know if we get a phone call at 2 o'clock in the morning, okay, fine, Nottingham can't offer apheresis, we're going to do it, and that it does give that resilience in the context of the service. But thanks, Alex. You wanted to come in? Oh.
No, it's okay. I agree
it's
with
okay.
that. I put my hand up by accident.
All right. But if no one has any further questions, then I'll leave it there. And thank you for offering us the opportunity to come and kind of just talk about the service and actually say thank you for your help in sort of looking after this patient, which I know wasn't necessarily easy. But the idea is that by getting the treatment right, we avoid these sorts of situations where the patients don't survive. So just I guess that's the kind of key learning point from my perspective.
Amy, that's brilliant. Thank you very much for sort of giving up your own time to come and talk to us about that. It's very helpful, actually, very useful.